Hello everyone, welcome back to Block On. I hope you have already watched all the three videos on lumbar plexus block tutorial. If you have missed it by any chance, please watch it from the link in the description and the comment section below. Today I am going to discuss few more important points and tips and tricks regarding the lumbar plexus block. So without wasting time, let's begin. The first point is related to the continuous lumbar plexus block. It is similar to the epidural catheter insertion technique. We need to advance the catheter in kephalar direction about 3 to 5 centimeter beyond the needle tip. Usually, the rate of local anesthetic infusion is kept around 5 to 10 mils per hour following an initial bolus dose. If you ask me, I don't personally use catheter because practically speaking, there is no added advantage of continuous lumbar plexus block over the simple block techniques like fascia block or femoral nerve block. It is also supported by the literature. In a comparison between the ultrasound guided lumbar plexus and the suprainguinal fascia blocks, the authors did not observe any difference in the morphine requirement for breakthrough pain control in the post-operative period. Actually, there are only few indications where we are using sole lumbar plexus block. Mostly, it is coupled with the sacral plexus block to provide complete coverage of the lower limb neurotomes. Hence, you have to put two catheters, one in lumbar plexus, another one is in sacral plexus. So, instead of maintaining two catheters, you can choose some other alternative mode of anesthesia, or you can use adjuvant like dexamethasone, which increases the duration of analgesia up to 16 to 24 hours. Next, the catheter migration is also a major drawback. It can migrate into the blood vessels or towards the intervertebral foramina, resulting in various complications. I will come to that later. According to the evidence from the literature and our personal clinical experiences, lumbar plexus block is preferred over spinal or epidural anesthesia because it provides unilateral lower limb anesthesia, especially in high risk groups with excellent intraoperative or postoperative analgesia. The problems associated with the epidural or the bilateral spread of the drug following lumbar plexus block includes hypotension, urinary retention, and nausea vomiting. When you use the sacral plexus block along with the lumbar plexus, sacral plexus block can also cause urinary retention. In this latest publication, Dr. Diwan and colleagues recommended PNS guided lumbar and the sacral plexus blocks as an alternative to the neuraxial blocks in early surgical repair of intertrochanteric fractures in ASA 3 or 4 patients. The authors commented that these two blocks are moderately difficult to perform, needs high vigilance during local anesthetic injection, and strict hemodynamic monitoring throughout the procedure. In this case series, the epidural spread was noted in 10% cases and the related dermatomal sparing, which I have discussed in the part 1 of this tutorial. The block usually sets in 15 to 30 minutes. The duration of analgesia depends on several factors like type, concentration, and volume of local anesthetic, addition of adjuvants, etc. We observed 18 to 24 hours of analgesia with 4 to 8 milligrams of dexamethasone when it is administered with 25 cc of local anesthetic. Lumbar plexus block is a deeper block. So, sedation and local infiltration is always advised. And if you are performing the block after spinal anesthesia, you can easily get the evoked motor response following the neurostimulation. But if you are planning to do it after induction of general anesthesia, please remember to avoid muscle relaxant because you won't get the evoked motor response if muscles are paralyzed. The first sign of block onset is considered as the loss of cold sensation over the saphenous nerve territory. Coming to the side effects or complications following the lumbar plexus block. The most frequently occurring side effect is epidural diffusion and bilateral lower limb block, which can also lead to significant hypotension. As I have mentioned before in the part 2 of this tutorial, don't seek for the quadriceps twitches below 0.4 milliampere. You might accidentally inject into the dural sleeve that can lead to total spinal anesthesia. The nerve injury incidence is very rare, that is 0.19% only, If you want to learn about the nerve injuries following peripheral nerve blocks, please go through our recent publications as you are seeing on screen. I will also provide the link in the comment section and the description. So nerve injuries can happen from the pressure effect of the Swas hematoma, and that can lead to plexopathy or neuropathy. It is better to avoid the lumbar plexus block in patients on anticoagulants, just like you avoid neuraxial block in such patients, where chances of hematoma formation is more, and also avoid catheter insertions in such kind of patients. Also, there are chances of vascular injury inside the psoas major muscle as well as around the intervertebral foramina, where the dorsal branch of the lumbar artery and the ascending lumbar veins are traversing. Other complications include peritoneal injection and the renal parenchymal injury. While doing the lumbar plexus block, as we are dealing with the structures close to the neuraxis, please follow a strict aseptic precautions to avoid the infection. Lumbar plexus block was also tried in supine position, but from my personal experience, it can be performed in pediatric age groups. But you need to place a wedge just beneath the hip, or you need to place the patient in semi-lateral position to gain access to the psoas major muscle housing the lumbar plexus and to manipulate the needle. In adult patient, it is very difficult. It needs further studies before recommending this technique. So to summarize, I personally feel it is very underutilized block, but it can do wonders. It is still considered as the advanced level block because of the depth and the vascularity around the plexus. I firmly believe with proper anatomical knowledge and sonoanatomy and skills, we can overcome this barrier. If you are listening to me now, I would like to advise you to start scanning for the lumbar plexus on volunteers. Scan frequently to identify the structures and for the cognitive training of sonoanatomy. Try to identify the lumbar plexus element, the structure surrounding it, especially the blood vessels, using color Doppler or power Doppler before performing the actual block. Another important point is that lumbar plexus block in old age and obese individuals are more difficult because it is very hard to identify the lumbar plexus element and differentiate it from the muscle tendons or striations. This is because of the increased echogenicity of the skeletal muscles in these age groups. I would like to conclude here with an important message. Lumbar plexus block should not be your first choice of anesthesia plan if you are planning to do it for the first time. That's all for today. I hope you have enjoyed all four parts of the lumbar plexus block tutorial. If you have liked it, please write yes in the comment section. It will motivate me to make more videos like this. And if you are visiting my channel for the first time, please subscribe it and share it with your friends and colleagues across the globe. We'll catch you in the next video. Until then, keep blocking, keep rocking.